Yes, the microphone is working. So once again, I would like to express gratitude to all the speakers, participants, and we have some more time, hopefully for a very fruitful discussion. So we just discussed how to make it the best way. So we have a number of questions written down, and we talk to colleagues. So simply we can start not from these questions which we prepared, but maybe from the questions from the audience. And then some of us may answer one by one. So any questions? Yeah, so questions to all the experts or just to someone personally? Vyacheslav? Yes. I want to ask Professor Cameron. John. Pancreatic anastomosis is a very important subject matter. Did you change the technique of pancreatic anastomosis in your life? And if yes, how many times? Microphone.
On?
Yes.
I changed the way I did pancreatocogegenostomies 100 times. Looking for a way to prevent leakage. There's no way. They don't all leak, but if it's a soft gland and a small duct, the chances of them leaking are 30 or 40%. If it's a big gland, if it's a firm, hard gland and a big duct, you know, they're going to leak. I mean, sometimes you don't need to leave a drain. You're so sure the anastomosis is intact. But generally, we leave a drain. So I think you learn a way that you're comfortable with. And I do a ductal mucosal anastomosis. I use a stent, and I invaginate it a little bit. And then I leave drains. And pretty much everyone in the United States has adopted the technique of at 48 hours, if you check the amylase in the drains, and it's 500 or less, you take the drains out. So the drains stay in for 48 hours in most patients. If at 48 hours, the amylase in the drainage, no matter what the volume is over 500, we generally leave the drains in. But I don't think there's any way. There have been so many prospective randomized studies. We've done octreotide, no octreotide, stent, no stent. We've done every conceivable prospective randomized study you can think of with the pancreatic anastomosis, and none of them have been positive. And I think it's impossible to prevent leakage. The important thing is, though, not whether the anastomosis leaks or not, it's whether you have it adequately drained. And if you have it adequately drained, it's not going to be a life-threatening complication. So yeah, I've tried every technique available, and I haven't found one that is leak-proof.
В продолжении вопроса.
Continuation of the question. There can be a situation when your drain doesn't work. Your drain doesn't work. And you need additional drainage, post-op drainage. What is then?
That is true. The vast majority that leak are successfully drained out your drains. But there will be an occasional patient that on the 5th or 6th postoperative day will have delayed gastric emptying, or will have a fever, or will have a white count elevation, and you get a CAT scan, and they have a collection. And then it comes in having a good radiology interventional laboratory, because then the patient goes to IR and has it percutaneously drained. And it's an uneventful procedure, and it takes care of the problem. Now, occasionally, the radiologist won't have clear access to the collection. And they say, we can't safely drain it. We're going to go through colon or go through your jejunal loop. But in those cases, it's almost always up against the stomach. And then the gastroenterologist can go in and with ultrasound identify the area of leakage, penetrate into it, leave a couple of drains, and that takes care of it. So pancreatic leaks are no longer life-threatening. That's the reason that 25 or 30% of patients died from this operation. But now, mostly with interventional radiology with percutaneous access or through gastroenterologists using ultrasound with transgastric access, those that aren't adequately drained with your drains can be managed.
Немножко конкретнее.
I would like to specify my question. In what percentage of cases, approximately, your drain approach did not work, was not adequate, and you had to send them for percutaneous or interventional radiologists? In what percentage of cases your drains didn't work?
I think in one of my slides, I think it was 7.9% go to the cath lab for one reason or another. And mostly it's for a biliary leak, which is uncommon, 1%. Delayed bleeding after 5 days, which fortunately is not very common, or drainage from your anastomosis that's been inadequately drained. So I would say 5% probably.
Спасибо. А можем...
Thank you. Can I ask the same question to my colleague, Yuri? How many times did you have to change the technique of pancreata anastomosis? Microphone! How many times did I have to change? Well, I cannot say in the percentage, but in my career, not most frequently. We pay a lot of attention to drain, to adequate drain, and I liked what Professor Cameron showed. John, we have the same technique of drain, the same. So behind the anastomosis on top and 2 more additional drains we put there, although we knew your publications, but still we are stubborn and we are doing the same. And we do not see any challenges and any problems at all in this respect. So yeah, our radiological service is also very good quality. Yeah, we make puncture if needed, percutaneous, and additional drains go. But I think this is not higher than 10%, I agree. Do I have the right understanding that your attitude to the publications which are coming and they tell us drain-free post-op management, what do you think? And your attitude to them is negative. Well, to my understanding, yeah, I have to admit it. When I was very young and very stupid, I love it. And I started working in abdominal department and I performed gastrectomies without drains, drain-free. But later on I understood, I became wiser and I understood that this is not quite right. And currently I'm the opposite. I'm against this method. John, the same short question to you. Drain-free method, your attitude, please comment on that.
Well, there was a time, I would say maybe 10 years ago, in some patients who had obstructive jaundice, a big bile duct, and a big pancreatic duct, and a very firm gland, that we wouldn't leave drains behind. And most of the time you got away with it. But it was not a huge number of patients. It might be 5 or 10%. But now that we leave the drains in only for 48 hours, if there's not a high amylase in the fluid, we've decided just to leave drains in everybody. And in 48 hours, if the amylase is 500 or below, we take them out. So there's very little penalty in leaving the drain behind.
Спасибо. Пожалуйста.
Thank you very much. Microphone, please. I have a question to the Presidium. Do you think it's possible, and if yes, when, big gland, soft gland, to perform standard pancreatectomy instead of Whipple? Do you think it is justified as a prevention of complications? Can I start? Would you like to start? Yes, of course. I wanted to ask you to start. I'm totally against. I'm totally against of such surgery. You know, patient will get disabled after that. No more employment, so disability. No, I think it's better to improve methods of anastomosis, to provide proper drains. You can drain this anastomosis through small intestine if there is a big risk, but you have to try as much as possible to preserve not just the life for the patient, but his performance status, to avoid disability. That's why we performed several surgeries, similar surgeries, but it was 20 years ago and never again. We never came back to that. Microphone. The question was, do you think it is justified please correct me if I'm wrong, to remove the stump of the pancreas if there are big problems of pancreatodigestive. Вы имеете в виду тотальную...
Whether to do a total pancreatectomy to eliminate, no, because, I mean, type 3 diabetes can be difficult to manage. And we actually, we've done 6,000 Whipples. I don't know how many of those were totals. I think maybe 600 or 700 would have been totals. We have 2 deaths from uncontrollable diabetes in that group. So I think, no. I don't think it's ever justified. I think there are occasions, first of all, we do margins on adenocarcinoma of the head of the pancreas. And sometimes if we don't get a negative margin, we do a total pancreatectomy. So I think it's justified sometimes, but as a routine, definitely not.
Здесь я могу сказать...
I can speak up about our experience because I mentioned in my presentation that in difficult cases of pancreatodigestive, we think this removal can be justified, but I cannot recollect the case we did. But when you have to remove stump and total pancreatectomy with complication, then you are thinking, why wasn't it done at the first surgery? Because unfortunately, patient usually came to this stage in a very severe performance. Yeah. Well, probably we have positive experience. Our task is to collect the data. We have quite positive experience of quality of life of patients with total pancreatectomies. Maybe due to the fact that we have very close contact with gastroenterologists, GPs, and they immediately transfer to proper department and they get joint recommendations of endocrinologists and gastroenterologists, and those who follow, they have good quality of life. You look at me and I know that you personally in Vishnevsky institution performed total pancreatectomy long ago, and the patient lived many years, and I always recollect that case. Well, if this is really life-threatening situation, that probably, theoretically, you can think it is justified. I don't know, maybe there are some other positions on that. You're welcome. Please take the microphone.
Quality, I mean, the surgeon has a good quality of life, not necessarily the patient.
No, we have experience with the patients also.
Добрый день.
Good afternoon. Well, it happened that the first total pancreatectomy I had to see, to follow, to initiate to a certain extent back in 1979. I think half of you were not born at that time. And at that time we had a big series, 16 patients, publication of 1983, total pancreatectomy in the Russian Journal of Surgery. Huge challenges. It was very difficult to manage in early post-op period. And actually that journey was very thorny and unknown. What to do, how to behave, how to manage them after total duodenal But in that series of 16, we managed to avoid any mortalities, no mortalities, and long-standing results and the quality of life. So very first patient, I remember her surname and I remember her name, Irina Yeremeva. She lived after that 21 years and died from lung cancer. And 20 years after total duodenal and I had an honor to demonstrate it in the Morse School Surgical College, and everybody in the hall decided that everybody died. And I was speaking, and they asked me, who was the surgeon? I said, well, actually, I myself and Dr. Vishnevsky. And they thought it was done in the previous century. But now the situation is totally different. So in fact, replacement therapy in the pancreatoduodenal resection, extended and long-standing disease also existing. And replacement not only exocrining, but also endocrining as well. But the other question is that regulation is better, but the options now of destabilization and identification, well, in every patient you can use AcuCheck and they can measure glycemia. So every 30 minutes, totally different diets, nutritional support, whatever. So yes. So in fact, it turns now into a standard replacement therapy. As any organ lost, no matter what you are losing, let's say, if it is coloproctectomy, so yes, it would be particular quality of life of the patient, but the patient is alive, and this is very important. But please don't pervert my idea. So if you can't perform total pancreatoduodenectomy, no, it's simpler to perform it. No. One anastomosis is minus, no leakages, yeah, have a rest, put a drain and forget about it. That's about the drain, yeah, with age. Somehow. Everything depends on the situation. If intra-op situation is life-threatening, and the most reliable way here to remove this threat, or at least reduce it, is to catch up and remove the residuals of pancreas. And it is not necessarily alive, viable, and functional. Then you have to do it without waiting severe bleeds. And patients, by the way, die from that more frequently than from the absence of pancreas. I'm so sorry. Well, we have to understand that in the post-op period you have to face also quite big challenges, and I would like to ask Professor Cameron. We talked to him yesterday. Probably it should be college decision. You should ask someone to the OR in order to understand whether you have somebody in your clinic more experienced who would put anastomosis here, because still it is less risk and it's better for the patient, definitely better. I cannot hear. Dear Professor Khatkov, dear Professor Cameron, I wanted to know, Whipple performed 3 surgeries back in 1935. They survived. In one case, he sealed the stump. Do you practice it now? Complete sealing of the stump, or there are some complications of such approach? We never do it now, because the threat of the pancreonecrosis in that case is very high. We never seal completely the stump, and I would never ever recommend it.
Actually, Whipple, of course, performed in New York City the first pancreaticoduodenectomy in the United States, and he performed 3 of them. Then the next operations were performed by a surgical oncologist also in New York at Memorial Hospital in the name of Brunswick, Alexander Brunswick. And he believed that you shouldn't anastomose the pancreas, and he routinely closed it. And he said, the risk is not getting the pancreatic fistula. That's not the great risk. The risk is getting the pancreatic fistula that is also mixed with intestinal contents. So there was a period in Memorial Sloan Kettering where Brunswick did exactly as you suggest. But I think time very quickly showed those fistulas rarely closed, and they took a long time. They caused complications. And so I don't think anybody routinely doesn't anastomose the pancreas. The complications of it are too great. But you're right, in the early pancreaticoduodenectomies or pancreatic resections, they rarely use the anastomosis to the jejunum. The other thing about with total pancreatectomies now and type 3 diabetes, you can have an insulin pump. One of the problems with type 3 diabetes obviously is insulin control of the glucose. And early on, there was an insulin pump developed at Hopkins maybe 30 years ago. And so 20 years ago, it started being implanted in patients who had hard to control type 1 diabetes, but also in patients who have type 3 diabetes. And it definitely makes management of the diabetes easier. But it's better not to have it, for sure.
Я хочу напомнить, что у нас
I would like to remind you that over here and over there we have morphologists, pathomorphologists, and conservative doctors, so you can use other questions and you can ask them. Igor, if possible, I would like to ask a question to Professor John Cameron. You know, I think here in Russia and in the US, there is also a big problem. What do we have to consider as borderline resectable tumor? There are radiological criteria, but how to navigate answering the question about the borderline resectable? Is it borderline resectable or not? So how do you navigate? What is your approach in your hospital, Professor Cameron? Or who makes the decision, the surgeon, or is it an X-ray radiologist decision? Who makes the decision?
Surgeon makes the decision, and that's a very good question, because borderline resectable and locally invasive, what does that mean? That means something different to every surgeon. And we are in the process of trying to be more specific about those diagnoses, but virtually everyone that comes in that doesn't have liver metastases now, even if the portal vein is occluded, the SMV is occluded, we've started to try and resect those patients. Some of them you have to do a shunt. You know, you get halfway through the dissection and the small bowel turns blue and congested. So we do a shunt from the SMV up to the portal vein, go ahead and complete the resection, and then do the reconstruction of the SMV portal vein permanently at the end. But more and more patients are who 5 years ago wouldn't have been resected are being resected now. Surgeons are becoming more and more aggressive, and it's definitely the surgeon that makes that decision. Now, with liver metastases, those patients get put on either FOLFIRINOX or Gemzar and Abraxane. And if the liver mets disappear, we go ahead and explore them. And if we find resectable disease, resect them. Or if they're just 1 or 2 and they stay stable during this neoadjuvant therapy with FOLFIRINOX or Abraxane and Gemzine, we will go in and resect the tumor and resect the metastases. We tried that 15 years ago and it failed miserably. Most patients were dead in 6 months. But now with the better drugs that we have, we're trying once again with a small burden in the liver to do the Whipple and take out the Mets if they've gone through a course of neoadjuvant therapy.
Иванович, а можешь спросить,
Can I ask a question? Who makes the decision, Igor, in your hospital? In your decision, Yuri, who makes the decision, surgeons or radiologists?
So surgeons make a decision in our department. Ну, кто же
Patient is going to raise their hand and say, let the oncologist, let the radiologist make the decision. They want the surgeon to make the decision. The person who's going to be in there in the middle, losing 10 or 15 units of blood, they want that individual to make the decision, not anyone else.
Вопрос ко всем докладчикам.
And now a question to all the speakers. If the past and present of the procedure is more or less clear, but do you see Whipple procedures in the future? Because the quality of life is different as compared with the chemotherapy. So this is a very interesting question. Really, site reducing effect is very high in this operation. It is a prevention of complications, hemorrhage, for example, this acute pains that cannot be resolved. So duodenal resection resolves these problems. I very often criticize myself for not making such an operation. For example, a patient died from hemorrhage a year after the follow-up, but he could have lived. That's why this surgery I think in the future we won't do without it. Of course, we have reached the limit, because as to the improvement of remote results, it won't give us anything. We cannot expand further if we remove half of the organism. We cannot remove the entire organism of the patient so far. And that's why I think we have reached the limit. But as to the palliative treatment, it will continue to develop and be used for a long time.
Let me answer 2 questions. First, quality of life after a Whipple. We took 100 patients that had a Whipple for benign disease, either an IPMN, a benign adenoma of the ampulla, whatever. We took 100 patients 1 year at least after their Whipple and compared them to 100 patients who had just had a laparoscopic cholecystectomy. The quality of life was the same in both groups. So the quality of life after a Whipple, unless you have cancer, is good, and you can get back virtually to a normal status. So that's the first question. The second question, are patients sometime going to be treated with pancreatic cancer without a Whipple? With anal cancer, a man named Negro in Detroit, Michigan, developed a chemotherapy and radiotherapy regimen for anal cancer 30 years ago. And in the United States, I'm sure here in Russia, if you develop a cancer of your anus, you're not treated with surgery. You're treated with chemotherapy and radiotherapy, and then followed with biopsies. And if you recur, you get surgery, but otherwise you don't. There's a Brazilian surgeon, I'm sure you're all familiar with, Haber Gama, who treats rectal cancer with chemotherapy and radiotherapy, and no surgery unless they recur. So you never want to say never to anything, because if I said pancreatic cancer is never going to be treated with just chemotherapy, radiotherapy, and immunotherapy alone, 50 years from now, somebody's going to say that jackass Cameron from Hopkins predicted this would never happen, and look, it's happening. So you never say never for anything.
Мне ничего не остается, кроме сказать, что да.
Да, ну что ж, I agree. Yes, we had several patients on whom we couldn't operate after some trial, laparoscopic invasion. We sent them to chemotherapy, and these patients are living with a good quality. They lived up to 2 years with a good quality of life. For example, the person with gastromatosis, abdominal. And he had a very good effect of chemotherapy, and twice we tried to operate on him. We saw these nodes on the abdomen, but he lived for 2 years in a good quality on chemotherapy. That's why I think medicinal therapy is the future of the medical progress. But the surgery won't disappear in the near future. And this connection, I would like to ask our experts on medicinal therapies. You have patients who receive neoadjuvant and adjuvant treatment after the operation. You see them, you know them. And subjectively or objectively, what do you think? Whose quality of life is better? Those patients that were not operated on because of borderline and they were sent for medicinal treatment, or those that were operated and then came for treatment? Who feels better? I would like to ask chemotherapists. I see several chemotherapists in our audience. You know, it is a difficult question. These are 2 different categories of patients. In principle, for patients who go to neoadjuvant therapy, it's mainly FOLFIRINOX regime. It is used everywhere. This is a very intensive regime, but 6 cycles is less than 2 months of treatment. Then, if patients don't get into the surgical group, they get stereotaxical therapy with the support of biftorfimidins. They feel well. During treatment, of course, we observe all the complications that exist, but then their quality of life in the future is not worse than that of patients who received operative treatment and then get ftorpirimidine or capecitabine plus gemcitabine. You know, Gem and Cap regime, you know, until you see the person who got this drug that looks like well tolerable, but when you see a person in your own family who gets such a combined treatment, and you see this person for a prolonged period of time, you see all the changes that are taking place, the loss of sensitivity, neurotoxicity, vomiting, hand tremor. Well, you understand clearly that it is better to provide an intensive combination from the very beginning than to provide oral drugs for half a year with all these toxic signs. That's the first thing that should be said. That's why everything depends on a specific patient, but really to endure adjuvant therapy is not an easy thing. And in a number of cancers, like colon cancer, for example, where the patient got adjuvant, so breast cancer, they give up Xylod for a long period of time, and they perform only 4 cycles of therapy, depending on the stage of the disease. Everything is very individual. There are patients, I remember one patient who underwent 18 cycles of FOLFIRINOX, but he felt very well and even worked. Very shortly, I would like a chemotherapist to speak very shortly. We have an opportunity to prolong our session a little bit. Very shortly, very shortly. Do you see such patients? You know, the surgeon is making a decision on in borderline cases. We have, for example, a person with pancreatic cancer. He has been diagnosed, and we have to provide long and high quality life. So what worsens his quality of life? Operation price treatment, or the treatment per se can worsen his life? What are your impressions? There are no official data, but what are your personal impressions? Of course, there are no exact data, but we see very many patients with pancreatic tumors. As to neoadjuvant therapy, they have the same side effects as metastatic adverse events at metastatic patients. And they, the only thing is they want to be operated on, but we cannot always offer operation after what we have already used. That is the main complaint. So it seems simple. This is a tumor, let us remove it, no metastasis. As to adjuvant therapy, we may say that since July, when there was an article published on modified FOLFIRINOX, we started to use FOLFIRINOX to all the patients, and 2 have already completed full treatment of 12 cycles of chemotherapy. And frankly speaking, we do not see any serious adverse events on FOLFIRINOX. Everything is tolerated quite well. Of course, there are fermentative insufficiency after such a hard operation, but if we correct everything with enzymes, everything is okay. Let me disagree. Professor Zhukova and I have had the largest experience of treating with such combinations. And this is a fantastic thing you are saying, FOLFIRINOX, that can be used endlessly, especially in the post-operative period. No, I would like to add to what has been said by Julia. what large experience you are speaking about? You have 5 patients and only 1 has undergone a full course. We have over 100 patients and they annually get treatment. Well, we speak only about FOLFIRINOX. Okay, now let us make any final conclusions. You have expressed your point of view, and let us listen to the point of view of Lyudmila Grigorьевна, please.
We have 300 patients who've had neoadjuvant therapy with FOLFIRINOX, and it's tolerated well. We give 4 cycles and then re-CAT scan them. And if they're stable disease or improved, we continue with FOLFIRINOX for at least 8 and sometimes 12. If they haven't responded, and about 1/3 of the patients won't respond to FOLFIRINOX, we switch them to Abraxane and Gemzar. And many of those patients, those 1/3 that didn't respond to FOLFIRINOX, will go ahead and respond.
Do you hear me? I would like to join what Professor Cameron said, to agree with what Dr. Cameron said. As to the decision of the solution of about borderline resectable pancreatic tumors, we stand for preoperative treatment first. These patients are mostly symptomatic, and if we make preoperative treatment, we manage to get symptomatic effect, and that allows these patients to gain weight, to get rid of jaundice, and it allows for those who don't progress during adjuvant therapy to be subjected to some radical treatment, stereoscopic radial therapy or surgical radical intervention. Professor Khatьков and I have been discussing this issue for a long time. And I may speak about our plans. So we plan to switch over to the maximal use of neoadjuvant therapy by modified FOLFIRINOX. It is a toxic regime, frankly speaking. Those chemotherapists who are present here and who have used this regime will agree with me. Tolerability is satisfactory, let us call it. It is an exception rather than usual practice. Of course, we manage to resolve some of the adverse events and prevent some side adverse events. But to say that everyone is tolerating very well, I can't say it. I'm ready to discuss it, because we see these patients. We see these patients every day. We are trying to prescribe to them this regime of treatment. Summing it all up, I must say that adjuvant preoperative treatment is welcomed by us, even for patients with conditionally resectable tumors, and we give preference to neoadjuvant therapy. And as a basic regime for neoadjuvant therapy, it is modified FOLFIRINOX, and for adjuvant therapy, if the state of the patient, it is FOLFIRINOX or GEM-CAP, which is more manageable in respect of tolerability. And the main idea today in chemotherapy is and it relates not only, it relates both to pancreatic cancer, gastric cancer, because treatment is tolerated better before the operation. The main chemotherapeutic load is to be given before the operation, increasing the number of cycles. I have already given the data of the trials that showed prognostically the number of cycles over 6 is a reliable prognostic factor for the increase of survival. That's why the main therapeutic load in such tumors is to be made on the pre-operational stage, because the surgery, no matter what the surgeon makes it, but it is 5 anastomoses to be formed, a long post-operative period, post-operative complications, and up to 1/3 of patients won't be able to get the adjuvant chemotherapy regime. They won't get adequate treatment. That's why if we want to achieve better results, surgeons will agree as well. It is better to make it all on the pre-operative stage. If the patient progresses, this patient would have progressed right after the operation in all the cases. So neoadjuvant therapy allows to cut off those patients for whom the operations wouldn't be indicative. Now a question to chemotherapists. John?
One comment about quality of life on FOLFIRINOX. Everybody is aware of the French study. It was prospective randomized that was in the New England Journal of Medicine several years ago, 6 or 7, 8 years ago, on FOLFIRINOX. They compared FOLFIRINOX to Gemzar. Now, Gemzar, in my mind, is almost a placebo. It doesn't help patients in the neoadjuvant or the adjuvant setting, but at any rate, it's frequently used by medical oncologists because it's not toxic and patients don't get sick and it's easily administered. In that study, in the New England Journal of Medicine, the quality of life in the group of patients treated with FOLFIRINOX compared to Gemzar alone, it was better in the FOLFIRINOX group. So I don't want to hear that FOLFIRINOX is a terrible toxic regimen. The most common toxicity is neuropathy in the palms of the hand and the soles of the feet, and it's troublesome. But it's not a toxic regimen. It is a safe, reasonable regimen. We give it to patients in their 80s. I'm in my 80s myself, so it's hard for people to argue with me about not giving something, surgery or drugs, in your 80s. And so FOLFIRINOX is safe, and it's usable in any age group.
Yuri Ivанович.
Okay, Yuri Ivанович, you wanted to ask a question or to answer the question?
I love all of them, and I understand that we cannot live without them, but yet, when I came to this conference today in the morning, I was absolutely convinced that if the patient is resectable, we should start from surgery. And the presentation of chemotherapists yet did not convince me. They showed many trials that are carried out on neoadjuvant chemotherapy, but the number of trials, even the number, is already saying that yet we do not have many effective and evidence-based data. So when I leave this conference today, what tactics do I have to follow? Maybe because of being Ukrainian, being very stubborn, obstinate, do I have to follow my previous way, or do I have to switch to neoadjuvant chemotherapy? And I have a question to Basin. If you're advocate of that, so why don't we do it? Why don't we do it? Well, we don't do it just because of the reason you just mentioned. Just because of that reason. Well, it's all good. Well, it's all good, but well, let's start doing it. Let's start. It's high time to start. I totally agree. But, you know, unfortunately, we have some social questions and issues in the randomization of patients to this or that group. Well, again, that's the point. That's the point. The decision is made by the surgeon. So at the moment, we are setting the issue of college-based decision. And if we are planning to do it, then we can. Let's say, let me put it this way, we can combine because not so many surgeons who are dealing with pancreatic surgery, in fact, even here in Moscow, not many. So I think we should get together and to discuss the issue, what's the best way to do it. But the only thing we should avoid any conflict in between, and we should take some external people not related to medicine, and we will give these people data, and they will carry out certification randomization independent third party that never ever saw the patient. So they think pathomorphologists should make the randomization, better pathology anatomists. Yeah. Yes, I have.
Такое экспрессивное было выступление нашего молодого химика.
So very expressive presentation of our chemotherapist, and you mentioned that we should measure MSI. No, we should not measure MSI to everyone. MSI is increased in pancreatic cancer probably in 1 or less than 1%. So if you don't want to make your lab bankrupt, please measure MSI only in the case if it really morphologically is indicated. And this is a particular type. And also about the marker, GGG, how you call it? Gata, yes. So this marker, especially if you're going to administer FOLFIRINOX, is of primary importance. There was a large clinical trial carried out, and they showed that low gata does not give FOLFIRINOX effect. So FOLFIRINOX doesn't work with low gata. So if gata is low, FOLFIRINOX is doubtful. I don't see the point. We don't need it. It would be inferior. It will be inferior. But this is just a comment. Yes, please, over there.
At first, you know, there's an old adage, don't be the first to accept change or the last. If everyone in the audience waits for prospective randomized studies to demonstrate neoadjuvant therapy is useful, you're going to be the last person on earth to help a patient with pancreatic cancer. The evidence is pretty strong right now that we should be giving patients neoadjuvant therapy who are resectable. Those patients have one shot. They can't wait for 10 years for a prospective randomized study. Start giving them neoadjuvant therapy today.
Yes, please. Thank you very much for a brilliant conference. I have a question both to Igor Khatkov and to Oksana. Oksana, my question is the following. Pre-op diagnosis of the tumor, what do morphologists prefer? Well, it is clear that the complex is very good. Puncture, endovascular ultrasound, maybe ultrasound, or maybe it's just aspirational biopsy. And Igor, the second question to you. For example, no chance of histological verification. What to do with chemotherapy? Is it really important today? Well, as the first question was to me, actually my presentation was reported and recorded by this news agency about pre-op morphological specimen. The best is definitely core biopsy, but at the moment endosonography is developed and you can get enough specimen from there as well. Well, it depends on the hands. It depends on the hands and the experience of the morphological group and on the communication with cytology group. If cytologists and morphologists are in consensus, and they already checked many samples before that, then definitely the sensitivity and the specificity of the diagnosis would be high. And chemotherapy, I think, hardly can be administered without morphological confirmation, but this is not my question. Well, first, very frequently, it is not possible to get the biopsy if the tumor is next to the vessels, so there is very high risk of trauma, or there was pancreatitis in the medical history and there is a lot of fibrosis. So let's imagine the situation when histological verification is not possible. Yes, it happens. It happens. Formally, according to the Russian legislation, we cannot start treatment of this patient. But again, I emphasize formally, we should get consilium and to assess all data, lab data, clinical data. The vast majority of the patients who have pancreatic cancers, I mean ductal pancreatic cancer, they have quite typical clinical picture and very typical habitus and some markers, clear markers. But the only challenge here is that in this situation we need to deselect neuroendocrinic pancreatic tumors, which are more favorable by their nature. But, well, everything is possible. Locally advanced, non-resectable, yeah, morphological verification cannot be obtained. But if we have high level of CA19-9, or if we have quite typical clinical manifestation, pain syndrome, because pain syndrome, like circumferential due to the infiltration to the nerves, if we have cachexia, then yeah, I think if we get consilium, we can make the decision on possible treatment to these patients. But if needed, we also should measure markers, serotonin and histamine, to exclude neuroendocrinic tumor of the pancreas. Do you have a question, Vyacheslav? Yes, well, we have many people, yes. My question is the same, simultaneously to John Cameron. You said, I think we should get consilium and administer chemotherapy if you do not have morphological confirmation. But from the legislative point of view, from liability point of view, that's my question to both speakers, John, to you, and to chemotherapists. The question is, do you do it? Yes, we do. John, do you do it without morphological confirmation?
Because almost always with EUS and fine needle aspiration, you can make the diagnosis. But if a patient clearly, and everyone agrees, we have multidisciplinary conferences, I'm sure you do too, with medical oncologists, pathologists, radiologists, surgeons there that go over every single patient that comes through our pancreatic cancer unit. If everybody is agreeable that the patient has pancreatic cancer and they've had 2 attempts at either a fine needle aspiration, EUS, whatever, we will go ahead and treat the patient without, but reluctantly.
Пожалуйста, вопрос дайте.
Question here. Я не слышу. I cannot hear.
Все, просто не представляете, какое количество рук поднимается. Давайте мы просто вот уже... Да. Пожалуйста, давайте. Виктор, я чуть... Пожалуйста.
Я кратко.
Very briefly, Igor. My question to surgeons. With the knowledge of chemotherapeutical efficacy, could you tell me, in what case are you going to operate the patient with oligometastasis? In what cases would you resect? And my second question, in resectable pancreatic cancer, in what level of CA19-9 would you send patient to neoadjuvant instead of surgery? Thank you. Igor, can you? Well, I already answered your first question. We have been dealing with the metastasis of non-colorectal cancers from ancient times. But there were also some patients with pancreatic cancers with big liver metastasis. We resected them. They didn't live longer than 6 months. Then we started trying to remove oligometastasis. Oligometastasis, according to literature data, to our own data, is when during the abdominal revision you find small lesion and it does not look like metastasis. You send it to histology and they confirm metastasis is there. Yes, we resected such patients, and I told you that we had 18 cases like that resected, and the median of survival was 7 months. So according to our data, to our experience, not much point. because the removal of very tiny metastases from the liver will not influence the course of the general disease if there is more than chemotherapy. What's the point? What's the point? Did you operate them after the chemotherapy? Definitely not. No. My question was different. In what case would you operate oligometastasis after neoadjuvant chemotherapy? Oh, difficult question. Most probably I will not operate at all. If after chemotherapy there is metastasis, we will send the chemotherapist to Dr. Bazin and he will continue treating. John.
First of all, CA19-9 plays no role in whether a patient is resected or not. Now, we'd prefer to have the CA19-9 low, but even if it's high, if it looks like it's resectable, we'll obviously go ahead and resect it. In patients who receive neoadjuvant therapy, we had the same experience 15 years ago in patients that had 1 or 2 metastases in their liver. When we did Whipples, we took out the metastases. The patients lived about 6 months. They obviously did not benefit from the surgery. But now with the newer regimens, with the FOLFIRINOX and the Gemzar and Abraxane, and everybody receiving neoadjuvant therapy, if they have a low volume of liver disease, 1 or 2 metastases, if they're stable or disappear, we go ahead and explore them. We do the Whipple, and sometimes we can find the sites of the prior metastases, other times we can't. If we can find them, obviously we resect them. So this trial has just started about a year ago, so we don't have enough patients or enough longevity to know whether it's a benefit or not.
Но у нас могу сказать, что нет такого опыта.
We have no such experience at all. Resections in liver metastasis neither before nor after the chemotherapy. No experience. I have a short question from 2 parts. What is the role of neoadjuvant chemotherapy in patients with complicated pancreatic head cancer, I mean jaundice and stenosis of duodenum? And can neoadjuvant be used in this category of patients? And if yes, how long can be the way from the first administration of the patient up to pancreatoduodenal resection? How long? Well, we have a standard situation. About 30% of patients with pancreatic head cancer, they do have jaundice, or before the treatment or in the process of treatment. It's not a problem. It is not a problem. We have a very good team. They put drains and, well, endoscopically, they put a stent. External drains very rarely, only if we cannot put endoscopic stent. The only thing that, yes, they somehow may ingrow, but in this situation, the only thing we ask them to do, especially when patients come from the other hospitals, we ask to implant metal, not plastic stents, which we have to replace every 3 months. Metal-based stents, well, they're better. They're more patable. Can I rephrase? Maybe I can rephrase the question because I understand. But with jaundice, yes, that's the first manifestation, most probably. But how much time do you need to assess the positive effect, if there is any positive effect from drug treatment, and then to refer the patient to surgery? Well, this is the standard protocol. After every 3 months, so you have positive effect. Will you continue treatment or you send to the surgery? If yes, when do you send to the surgery? Well, we talk to surgeons. So actually, we treat 6 weeks because every 6 weeks we have examination, and then we have medical consilium, and this is surgeon, radiotherapist, chemotherapist. Yes, all together. We simply look at the case, we look at his or her condition, we look at the lab tests, the results, we look at the picture. So I have an apology to make. You know, 6 weeks. Do you think 6 weeks is sufficient enough? If everything goes well, so patient is good, effect is here, tumor shrinked, and surgeons are ready to take. Do you think 6 weeks is enough? 6 weeks is enough? Well, let me count. 1, 2, 3, 4, 5, 6 cycles. Yeah, FOLFIRINOX. 6 cycles. Why not? Yeah. Well, up to 6. No, not 4. 6.
FOLFIRINOX in 6 weeks. A cycle takes at least a couple of weeks. And I mean, virtually every patient who presents with carcinoma of the head of the pancreas is jaundiced. And now they all have to be decompressed. Obviously, endoscopically, it's the easiest, but if that fails, they're decompressed percutaneously. And then, however long it takes to give at least 4 cycles of FOLFIRINOX, and if they're stable or shrunk, you continue on to 8 or 12 cycles. If they have progressed, you switch them to Gemzar and Abraxane. Every patient needs to be decompressed. No medical oncologist is going to give chemotherapy if the patient's jaundiced. They have to have their jaundice relieved first before they get their neoadjuvant therapy. And then that goes on literally for months.
Так, пожалуйста, давайте.
Emphasize one other point. These patients shouldn't be followed just by a surgeon, just by a medical oncologist, just by an internist. They need to be followed in a multidisciplinary clinic, which meets once a week. And the surgeons have to be there, not every pancreatic surgeon, but one pancreatic surgeon has to be there. The medical oncologists have to be there. The pathologists have to be there, the radiologists. These patients should not be followed by one practitioner. They have to be followed by a multidisciplinary clinic.
Здравствуйте, Руслан Мушуров, неонколог.
I'm from Herzen Institution. I have 2 questions. My first question, what is your attitude to octreotide? Do you use it or not? Because we see some publications that they say the drug is not efficacious. And my second question is, what methods do you use? Surgical, drug, intra-op? How do you fight with pancreatic fistulas? Yuri, can you start? Octreotide, with what purpose? Patients who have neuroendocrinic tumors? No. Prevention of post-op complications. Preventions of post-op complications. If it's soft gland, we always administer. What? How do you identify that this is soft? You touch it, well, during surgery, of course. Tactile feelings. Well, we have ultrasound methods as well to measure the density of the gland, but they just started, and yet we did not find adequate way with pathomorphologists. Yes, we have some mismatch with them, but one day it will come. Yet, yes, it's just palpation during the surgery. Yes, but we administer simple or prolonged octreotide.
We've done a prospective randomized study with, I think, about 100 patients in each arm following the Whipple, octreotide, no octreotide, absolutely no benefit. There was a more recent study with the next generation of octreotide in the New England Journal of Medicine from Memorial about a year ago, maybe 2 years ago, which did show some benefit. But it's been refuted, the study's been refuted on multiple occasions. Now, once you develop a fistula, should you give octreotide? Does it decrease the time to closure? We do give octreotide in that situation, but there's never been a study that demonstrated it's clearly efficacious.
Так, пожалуйста.
Morphologists. Let's give the floor to morphologists. My question to Professor Komeron and to Professor Khatьков and representatives of Russian centers and United States representative. We have been talking about adjuvant chemotherapy, adjuvant which is after the surgery. Please correct me if I'm wrong. So you have specimen from the surgery. When you administer adjuvant chemotherapy, do you have a differentiated approach? You mentioned something about GATA6, but as a protocol, do you have a protocol who to administer FOLFIRINOX and who to not? Because squamous does not react to FOLFIRINOX, and we know it for 5 years already. So any differentiated approach, post-surgical session, so that means whether your chemotherapeutical regimen depends on morphological picture. Do you have does all of them have? Well, I hope in the future it will depend, but right now, in principle, we should select this or that regimen of adjuvant chemotherapy. We should take particular markers. Unfortunately, right now we are quite limited in these tests, especially genetic, molecular, and other tests, due to the absence of reimbursement of these tests. Estrogen, progesterone, HER2 negative. What do you do in such case? Do you do in such case? No, in such case, no. No, in such case, no. Because again, I'm telling you, it is not reimbursed by the insurance companies. But to detect and to measure some markers, to identify better sensitivity to this or that type of treatment, well, it can be done only out of pocket of the patient. As you understand yourself, patients are not very happy to pay for these tests, so they're not eager. Well, we need to speed up. I have to say that we are definitely living in a transition area because we even don't know what happens in the healthcare. Molecular genetic testing from the new year is already reimbursed by the obligatory insurance, so you can perform it and you get compensation for that. But the question is how your administration is making decisions. So I'm ready to comment on that later on behind the curtain. So because I can share how we do it. Because there was a question to Professor Cameron. Does chemotherapeutic regimen depend on morphological conclusion?
No, not currently. There are no we know, first of all, in the post-operative period, in the adjuvant period, you don't know whether somebody's responding to the drug or not as a rule. The criteria for response, no response aren't set. Now, in the neoadjuvant period, you can tell. And after 4 cycles of FOLFIRINOX, if there's progression of the disease, as there will be in about a third of patients who can't clearly be identified molecularly yet, but I'm sure soon they will be, a third won't respond, and then you switch to Abraxane and Gemzar. If the tumor is the same size or shrunk, you continue on with FOLFIRINOX, but there's no more science involved in it than that currently.
So these days, no chance.
No.
Был ответ уже. Спасибо. Пожалуйста, вы хотели вопрос задать.
Thank you very much. My first question. Please introduce yourself, those who ask questions, because people do not introduce. I am Dr. Pronin from Bryansk. I have some doubts. Brilliant presentation of our distinguished guest, Professor John Cameron. Brilliant results. Huge randomized trials, huge experience, lots of evidence-based data. And there is a discussion. It's like reinvention of America, rediscovery. So please provide your question, because our time is almost over. Please formulate your question. My question, I think all the dots are already over the eyes, but we are again trying to re-put them. Do you have a question? I have many questions, but there are no answers. Thank you. Thank you very much. Please give the mic to somebody else. Oh my God. Oleg, please. Yes, all the dots over the eyes. Stop it. Well, I am from Moscow Clinical Research Center. Dr. Cameron, you are the advocate of Whipple in high-flow centers, high-volume centers. According to what principle do you select your residents? Isn't there any risk that after your training, they will not get to high-volume centers and they will spoil the method? And my question to Oksana. Second question, just a second. Today we saw that according to Karolinsky protocol, about 60% are one resections. What's the point? Why don't we have it here? Do Russian surgeons have better surgery, or Russian morphologists are blind?
In answer to the question of what do our residents do who have trained in a high volume center and they go someplace else, the answer is they create a high volume center there. Lily Moe went to Indiana. He then went to Massachusetts General Hospital. Yo went to Philadelphia. Schulich went to Colorado. Chody went to... We've populated the country with pancreatic surgeons, and they've gone there and they've developed pancreatic centers, and they've become high volume. Now, eventually that string's going to finish, and every city is going to have a high volume center. But that's not the case yet in the United States, and there's still room for more pancreatic centers, and we're training more people to go out and staff those.
Скажите, а вот меняется это?
Is it changing with time? Because, you know, one thing, there was situation in the mid-80s and 90s, and this is exactly as you said before. Nobody wanted to deal with pancreatic surgery, but the situation now is totally different. When everyone wants and everyone believes that he or she can do it, especially if he had residency in a high-volume center.
That's true, and eventually the country is going to be saturated with pancreatic surgeons, and then there'll be another field that becomes hot, and they'll start being trained in someplace else and populate the country in that field. But so far, there's still a need for pancreatic surgeons. Our residents and our fellows finishing their time at Hopkins are very, very much sought after to go to other institutions in the country.
Да, может, я отвечу сейчас? Я бы хотела сказать, что в первую очередь там R0...
R0 was after neoadjuvant therapy. I gave an example of the American College of Morphologists, but the thing is that our experience shows that R1 is not more than 30%, so the surgical technique is very high in low volume centers. As to the morphologist tests, they are more and more standardized because we advocate, we advertise it, we have courses, we teach morphologists and hold large conferences. I hope that the standardization of the protocol is gaining momentum, and those morphologists who worked in high volume centers, they adhere to these standards, and the figures of R1 are comparable with the R1 figures in the United States. If we look at the literature, 80% of R1 is mentioned by morphologists, and the surgeons say vice versa. I quite agree with this thesis. R1 resection occupies 70% in our center. And I talked with the famous morphologist, and he said that this is the problem of morphologists. If it is good, he finds in 100 cells in 100%. When Katya Moroz from our clinic goes on vacation, we don't have R1 resections. When she comes back, this number is large. When criterion is 1 millimeter, that's the way it will be. It depends on 1 millimeter.
From the beginning, we've had 70% R0 resections and 30% R1. We've had 20% node negative, 80% node positive, and that's been consistent for the 30 years or so that we've had pathology that's worked diligently on the specimens. So I think it is possible to have an R0 resection in the majority of patients. Lymph nodes obviously are beyond our control, and it's 70–80% are positive.
Можно вопрос задать, который мучает меня?
I have a question that has been torturing me for the last 40 years. All right. So a yellow patient, he has a cancer. So we made the injection. Well, no, cancer markers are normal. Radiologists, something, they see something is special. So thickening of the walls. Will you make Whipple to such a patient? And probably Oksana will tell me how many complexes, in how many complexes the cancer is not confirmed. We will not only make Whipple, we have been making it for a long time. There are very many patients when we cannot get a morphological confirmation of the diagnosis. Then in the complex with the radiologists, chemotherapists, we make a clinical diagnosis cancer and make a surgery. And in 90% of cases, we prove to be right. No, 10%. So you said 10%.
Now, when everybody in the audience, I know, is going to start giving neoadjuvant therapy. I'm convinced. And to give neoadjuvant therapy, you have to get tissue. Before, when we saw patients with clearly resectable lesions, we went ahead and did the Whipple without getting tissue confirmation. And we had the same results as everyone else. 10% didn't have cancer. That's going to decrease now because we have to get tissue confirmation before they get neoadjuvant therapy. And you can obtain that in 99% of patients. So that false positive Whipples are going to decrease.
Если ко мне был тоже вопрос, Виктор Ильич, так мы же это делаем, вы же нас этому научили, я хочу сказать. Там Роман Евгеньевич вот хотел давно.
I have a question to Professor Cameron. So you advocate now neoadjuvant therapy. What method of compression do you choose? Stenting? If it is stenting, what modification of stent do you use?
I think it's preferable to endoscopically stent a patient. That's a lesser invasive procedure than doing a percutaneous transhepatic stent. And this is beyond our control, but the gastroenterologists always now use a metallic stent. They get paid more for putting a metallic stent in, and they put metallic stents in. And we don't complain because sometimes the neoadjuvant therapy goes on not only for 3 months or 4 months or 5 months, but 6 or 8 months. And they're going to have a plastic stent changed a couple of times. Now, if we can't decompress them with endoscopically, we obviously go ahead and percutaneously and transhepatically decompress them, but preferably it's endoscopic.
If it is a metallic stent, is it a graft or a stent that is not eluted?
There are various types, but usually it's a covered stent. It's a covered metallic stent. And they last invariably for months and months and months and don't have to be changed.
Евгений, большое спасибо за конференцию. Два моих коротких вопроса. Доберман, Архангельск. Скажите, пожалуйста, цитологические подтверждения диагноза при эндосонографии является основанием для назначения неадъювантной химиотерапии или нет? И второй вопрос. Оксана Владимировна, видно, что вы этим очень так болеете, этой проблемой. Скажите, пожалуйста, какой процент, то есть какова чувствительность frozen section, когда вот мы выполняем резекцию края, какова чувствительность вашего метода исследования и как часто возникают ложноположительные результаты, которые требуют нам расширять объем резекции поджелудочной железы? Спасибо большое.
Но
I'm sorry, I didn't hear the beginning of that question. Are you talking?
Я не слышал начала вопроса. Вы говорите...
Pathology under sonography is there enough material to administer chemotherapy, and the second the sensitivity.
What is the question?
She's asking it in English.
During the endosonography, is it's enough to administer the chemotherapy? Is the first question, and the second, what is the sensitivity of frozen section during the operation?
Well, first of all, I think that the accuracy of endoscopically with EUS getting a false positive would be close to zero. Getting a false negative might be 5 or 10%, and it may have to be repeated a second time. And the second part of the question was for neck margins. Neck margins are high with our pathologists in our lab. They're highly accurate, but I would say in about 5%, margins that have been read as negative, subsequently a week later, we're told is positive. We don't go back and re-resect those patients, but those patients for sure get radiotherapy. You know, radiotherapy in the adjuvant setting is controversial. In the United States, our radiotherapists, obviously, they think radiotherapy is a benefit. The European studies show it's not only benefit, but that it's actually harmful. So it's not clear in the adjuvant setting whether radiotherapy is any benefit or not, but we would definitely give it to the area of the pancreatic duodenectomy and anastomosis if later we found out that margin, which had been initially called negative, was positive.
I will give an answer a bit later. We have some period of time for two short questions. From our experience, I would like to say that if we have enough material for a marrow biopsy, we can detect cancer, but sometimes we have a negative receipt of the material. There is no material for morphological test. And if they repeat it 2-3 times, then we make core update in our clinic if it is possible. Then frozen section of the pancreatic resection margin. Even morphologist, even if the morphologist is in doubt, he will express his assumption into hyperdiagnostics instead of so he will say that really some complexes are suspicious of cancer. If it is possible, probably it is to step from the margin of the resection. But there are very few cases. So clear update section of the pancreas is quite enough. Ishenko from Moscow. As to the vascular resection, after neoadjuvant treatment, do you do it along the old margins or along the new ones? Along those that exist. It is quite natural what I see, the margins I see during the operation, and I go along them.
In my talk, I didn't mention vascular resections. We resect the portal vein, SMV, occasionally part of the SMA in about 15% of cases. Now, we as well as everyone else over-resects vessels because when you look with the portal vein or SMV taken out, when the pathologist looks at it, it's usually not invaded by tumor, whether they've had neoadjuvant therapy or not. So we over-resect to be on the safe side. It's become very safe now. You know, 20 years ago, it was sort of a dramatic thing to resect part of the portal vein or SMV. But today, it's sort of routine. And so we routinely do it when there's a question of invasion. But generally, the majority of those patients, the vein is not invaded.
Пожалуйста.
My question is on post-resection reconstruction. Do you do an isolated loop or do you do a roux loop?
We do pretty much a standard reconstruction with a pancreatocogegenostomy to the loop of jejunum just beyond the duodenum. And then we do hepatocogegenostomy, and then a duodenogegenostomy or gastrojegenostomy. So it's sort of the standard routine. Now, we did a prospective randomized study adding a bron below the afferent and efferent loops, thinking that the afferent loop frequently did not empty well, and that caused delayed gastric emptying, and it also blew up the afferent loop and caused leakage at the pancreatocogegenostomy. So we figured we'd do bronze and cure both problems. It didn't cure either problem. And so we stopped doing bronze and just do the standard reconstruction.
Вячеслав Иванович, ваш вопрос.
Please, your question. Two short questions. John said, then with resectable tumors, the level of CD19 is of no importance. C19 1000 resectable tumor, is it of importance? That's the first question.
That patient has a lesser prognosis than a patient that has a CA19-9 of 30. But it doesn't mean they're unresectable, and it doesn't mean that they cannot survive for an extended period of time.
Я имею в виду, нет ли смысла ему назначать не...
Is there any sense in prescribing neoadjuvant instead of surgery?
Because everybody gets neoadjuvant. You don't have to make a decision about who gets neoadjuvant and who doesn't, because they all get it.
Спасибо. И у меня еще один вопрос.
And one more question. When we speak about the level of R0 resection of 70%, do we mean an American classification or European classification of pathologists?
We use the classification, if it's a millimeter or less, it's a positive margin. Our pathologists say it has to be 2 millimeters to be a negative margin.
Спасибо.
Я думаю, что...
Well, I think that we have spent enough time on the discussion, because you have begun to repeat your questions, and we repeat things that we have already said. I would like just to pay your attention to the fact that half of the presentations were made by surgeons, but the discussion was devoted to the issues of treatment, of multidisciplinary approach to the treatment of the disease. It just confirms that the problem is difficult, and there is no one approach to it, and these patients are to be sent to multi-profile, high-volume centers where there are adequate teams that could solve the issues in respect to each individual patient. And I would like to thank everyone for the participation, for active participation. I'd like to thank our speakers, Professor Cameron, who has arrived from far away. These are really excellent experts, and we take a lot from them, and I hope we will manage to organize similar events. And at the beginning of July, we will have a separate conference in continuation of this Pancreatic Club meeting. And to more tomorrow we will have a meeting with young doctors where we will teach them to write articles to foreign journals of medicine, and there will be just some foreign speakers, and you may join. I saw many people to get photographed with John Cameron. Probably we will make a kind of make a number of photos here on the stage with Professor Cameron. So I will ask my dear colleagues and speakers to stay a bit longer, and let us make photos with them. Thank you.